ER, the complaint was increased vision. And this is a 70-year-old right-handed male. He had a history of some confusion that improved. And it was confusion and also some slurred speech. This lasted about 2.5 hours ago, and it was in 2013. He did not seek any medical attention. Most likely, as you can imagine, this was maybe a TIA, but he did not seek any medical attention, so didn't have any stroke workup at that point. The day of admission, the patient woke up and noticed that he had some vision loss. The time of onset wasn't determined since he was asleep when it happened. And to review the systems, the only thing at that time was the vision loss. He did not have any allergies. He did have a past medical history of diabetes, high blood pressure, and hyperlipidemia. As you all know, these are all risk factors for stroke, including his gender and his age. He did used to smoke about 10 packs a year and denied any alcohols or drugs. Physical exam, his vital signs were stable. There was no other abnormality except the vision loss. And the vision loss, doctor described it as left homonymous anoxia. But I wanted to show you what that means is that the half left side of his vision was one that he could not see. So this is basically what he could see, our area in white. And what I have here is something that we use a lot, and I'm going to go through it a little bit more in another slide. It's how our visual system is really complicated. And one area sees one part and then it crosses. So depending on what the visual field defect is, it can give us an idea of where the lesion can be. His sensory was intact. He didn't have any numbness and tingling. He didn't have any weakness. This is something also that we sometimes use. This is the motor system, 5/5, meaning that everything was normal. And this is also something that we usually use for the reflex 1+, which is not uncommon for diabetics not have their reflex in 2+. And this means that he didn't have the Vinsky, it was plantar flexor reflex. So this was his CT scan. As you can see, these are the ventricles. We don't see any areas at this time suggestive of stroke. Usually a stroke, you will see a dark area, and we're going to see it in the MRI, how obvious it is. But in the CT scan, especially in the first 24 hours, sometimes you don't see the acute findings of ischemia. Now, why it's important to have a CT scan when a patient comes with stroke-like symptoms to make sure this is not a bleed. So if it is a bleed, then we can see it right away in the CT scan. And that's why when a patient is a TPA candidate especially, we need to do a fast CT scan, make sure there's no bleed, so that will be one of the major complications. So at this point, with the physical exam, we could discern that the patient had an acute stroke. Why is it the right occipital stroke? I'll explain in a second. That's because of the pattern that he had of the visual field defect. And at this point, the plan for us was to do more stroke workup, including a CT angio of the neck. And when we have some compromise to the posterior circulation of the brain, one of the things that comes to mind will be arterial dissection from the vertebral or the posterior area of the brain, especially in young patients. If there's a history of trauma, this is one of the things that we always have to look for. Also, the patient was started on aspirin and statins and was admitted for close monitoring. So this was the MRI, and these are different sequences of the MRI. I don't know if you can see well, but this is the one that we use the most for acute stroke, and it's called DWI. And when this area is bright and it's dark, and another one that I don't have here, we correlate the DWI with another sequence. That usually means an acute stroke. So we can see how this patient, this is the right and the left side. This is the occipital lobe. We can see how this patient was already having the damage to the right occipital, which would cause the left visual field defect. This was a CT angiogram. I just wanted to show you this. He did have a lot of intracranial and also neck narrowing, which is also very common in diabetics and older people, history of smoking, but there was no dissection in his case. This is a diagram just for you to see the different blood supply that the brain has. And as you know, we have major arteries that go into our brain. One of them is the MCA, which is one of the areas in the middle cerebral artery. That's one of the areas that it gets compromised very commonly in stroke. And as you can see, it's all this yellow. It irrigates a big part of the brain. So when we have a total occlusion of this, is when we see the typical patient that will have a complete, weakness of arm, leg, and face. And depending if it's total in which area, the patient can also be very obtunded, poorly responsive, depending on which, if it's the right or left area, and how much of the compromise it's involving. And these are also, the larger the stroke, the most likely to have edema and also herniation and endangerment for death. The PCA, this posterior cerebral artery, which is the one that we're discussing, is this part, the posterior part of the brain, but also gives some deep branches for very, very important structures that are in the middle of the brain, or the deep structures in the brain. The anterior cerebral artery is the one that goes here, and I don't have a cut, but it has more territory involved. This is just one slice. And when we have strokes from this area, sometimes they can present only with leg weakness. And it can easily be misinterpreted by something else, maybe a back injury that is just causing leg weakness, but it can also be a stroke in this territory. And this is just to highlight the area that the posterior cerebral artery irrigates. So as you can see, there are important areas: the cerebellum, the pons, midbrain, and all this area of the occipital lobe. So it is not only vision that it can compromise; it can compromise several aspects of the neurologic function. And this is to explain a little bit how the visual fields, as I said, they are a little bit complicated. So if we're looking to the left, our eyes, the nasal area looks to the contrary side, and the temporal area looks also to the other side. So we see in each eye it's crossed. And then as we go in, the part of the middle, or the nasal area, is the one that crosses to the other side, and the other one stays the same. So you can imagine how, if you have a lesion here, it will be different because it will be compromised in these sides, and the visual field will be at each side. So depending where the lesion is, it can give us a hint of where, of the visual, depending what the visual findings are, it'll give us a hint of where the lesion is. So in this case, if we have a lesion over here, and the right side, then, as you can see, the ones that cross, what we're going to have will be a left visual field defect. And this a little bit also, so the PCA, within the occipital lobe, there are other areas that are different small arteries that irrigate. So depending also if it's the whole PCA that is involved, if it's only one of the little branches, you can also see different changes in the visual field. I'm not going to go very deep into this. It's just for you to have an idea of sometimes how complicated it can be. This is a very interesting article that I found was just published a year ago. I placed here the reference in case you wanted to look at it, because it talks a lot about posterior circulation stroke. It also gives important tips, how to identify it, why it's important, and also what are the differences with other strokes in other parts of the brain. And posterior circulation stroke accounts about 20 to 25% of the ischemic strokes, so it's not rare, it is fairly common. Also, the TIAs that can come from the posterior stroke can be sometimes brief or minor brainstem symptoms, and sometimes this can be misdiagnosed or can be overlooked. Acute neurosurgical input can sometimes be needed, As you can imagine, if you have a large cerebellar stroke, the risk of that, if they have edema, swelling, and causing brainstem compression and even death is sometimes high. So in this case, neurosurgery sometimes has to open and take a piece of the bone while there's a lot of edema until that gets again to normal size and they put the bone back. But these are measurements that can save the patient's life. Also, vascular occlusion. Vascular is the artery that feeds the posterior circulation. It can be associated with high mortality, severe disability, especially if there's blood flow that is not restored in that vessel. And this will be the same for many areas of the brain, but you can imagine if you're irrigating the brainstem, that is a very important part of that can cause death and cardiac arrest and many others. So what are the differences between posterior and anterior circulation strokes? One of the main differences are that the value of screening instruments sometimes is not the same. For example, this test, the FAST test that you are all familiar, the one that we ask the patient to raise the arm and we see if he has drooping heads, that was intended more for the anterior circulation. It's not that helpful for the posterior circulation. It's always helpful in stroke, but you can miss some of the signs because patients can present with vertigo and some difficulty swallowing. It can look like maybe something else, even like a ear problem, and sometimes it can be a lesion in the midbrain or in important structures. So with the FAST, if we do the FAST exam, we can miss that. Another important thing is that imaging, especially CT, is not really good to see the lower part of the head. And the reason is because we have more bone, so there's more artifact in that area. So whenever we suspect, even if the CT scan doesn't show anything in the pons or in the lower part of the brain, it doesn't mean that it's not there. It's just that there's more artifacts, so CT scan is not the best test for that. An MRI will be more specific. But as you all know, sometimes we cannot have an MRI, either because of pacemaker or chronic indications, or because of time, or many areas there's no MRIs available, so that is something that we always have to have in mind. And what are the symptoms? As you can see, I'm not going to go through all of these, but as you can see, symptoms can vary. It can go to weakness, clumsiness, or complete weakness of arms and legs, depending where the stroke is. It can also cause cross syndromes. It can also cause sensory deficits. In our patient's case, the homonymous meninopsia, meaning the defect in the visual field both on one side, either left or right, depending where the stroke was. It can cause imbalance. It can cause vertigo, with or without nausea, double vision, difficulty swallowing. So as you can see, the symptoms can be practically anything. And this is also something that was in the article I thought was very useful. What are the tips as a non-neurologist that we can have to identify posterior circulation stroke? So what they recommend is careful history, taking a careful history, especially time of onset, if there's recurrency of the symptoms, if our symptoms are getting worse. Also, of course, the clinical presentation to see if there's any visual field defects, any eye abnormalities. This usually is performed by initially the nurse is the first contact to the patient many times, so it's very important for all of us to be trained at least in the basic neurological evaluation. And also other things are to, this will be more for the physicians, to investigate if there's have been any transient ischemic attacks, the MRI, of course, and this is also consider referring the patient if there's any deterioration, if there's any, basically this is to have a low threshold to put the patient in an ICU setting, because if there's a stroke, that there's a risk of swelling that can happen very quick and can cause the life of the patient. Sorry. Any questions for me? The next case that Dr. Cruz is going to present is also of posterior circulation stroke. You can see how different sometimes it can present. So far, any questions? Thank you.
Good morning, everybody. I'm Jansen Firdousi, UI2 neurology resident. So I'm going to present the case. It's exactly just a continuation to the Dr. Avila, the postal circulation stroke, how they can present differently. So chief complaint was lethargy and drowsiness. This is 67 years old female, right-handed Spanish speaking, came to the emergency room because of the drowsiness. Daughter reported she was fine the day before and she's sleeping a lot today. She came to the emergency room after initial evaluation that was TIA and sent home. Next day, the daughter brought her again due to excessive sleepiness, and between this drowsiness, she's arousable but not communicate or can keep the verbal communication was not that good. That time she was admitted to the hospital and neurology consult was requested. Review of the system, nothing remarkable. The past medical history, hypertension, diabetes, and hypothyroidism. She smoked cigarettes 4 to 5 days. Mother had dementia and diabetes, CAD. Medication was plasma-free and levothyroxine. Physical examination, vitals were within normal limit, and neurological examination, which was alert-oriented to time, place, and person, but she was very drowsy. And all cranial examination was normal except the vertical stigma. Other rest of the motor and sensory examination was normal. That is only vertical stigma and drowsiness. Even coordination and cellular function was normal. Most of motor stains, gaze, everything was normal. This is the initial CT scan. Initial CT scan did not show any acute finding that can suspect like this is stroke. The patient had MRI done, and it shows, you can see here, very hyper-intense white, this is DWI sickness, and ABC is corresponding to the hypodense. So that means indicates the acute stroke in the region of thalamus, and it's like a bilateral. Rest of the stroke workup was negative, including MRA, head and neck, and echocardiogram. Our impression was acute bilateral thalamic infarction, either from small vessel disease or from embolic cause. Now let's talk about the thalamus. What is the thalamus? Thalamus is a part of the brain. It stays between the cerebral cortex and brainstem. This is the brainstem pons, and this area is the thalamus. The main function of the thalamus is the motor and sensory signal to the cerebral cortex, and also it regulates the sleep, alertness, and wakefulness. Their burst of thalamic function, it depends on what thalamic nucleus is involving. That's the gross function. And the blood supply of the thalamus is the 4 major vascular territory. One is the tubulothalamic or the polar artery, paramedian branch of the basilar artery, infralateral of the thalamo-geniculate artery, that's and the posterior-parietal artery. All are the posterior cerebral artery branch. This is the posterior communicating artery branch. Another artery, we say the artery of Persson. This is the rare anatomical variation of this posterior circulation. So usually all patients doesn't have this artery. This is the variant, anatomical variant. Some patients have this. I don't have the statistics how many percentage the patient have this variant. And it also supplies the bilateral side of the thalamus and midbrain. So this is just the gross, this is the thalamus and how the blood supply goes, how many arteries. This is the thalamus-ophthalmic artery, the polar artery, branch of the posterior communicating artery, and this is the thalamo-geniculate artery. Supply the thalamus. This is also the same diagram for the thalamic blood supply. And this is the artery, partial artery. Sometimes it may arise from posterior circulation independently from right and left. It may arise from one side and supply this to thalamus and midbrain, or it may arise from the posterior communicating artery and supplies both sides, or thalamic infarction is also depends like which part of the artery is involved or what and which part of the brain can involve. Occur like this one, this and this. And the presentation will be completely different part of the thalamus. So I'm talking about only the partial artery occlusion symptoms. It's not the whole thalamic occlusion. The whole thalamic occlusion can cause a different presentation. That's the doctor a bit of explain and present with the sensory deficit, motor deficit, homonemia, impia, tremor, or some polio-active form movement. This is only for the partial artery occlusion stroke. Bilateral paramedial thalamic stroke are typically characterized by altered mental status, vertical gaze, and memory impairment. Altered mental status can present from drowsiness to confusion or somnolence, even coma. And that our patient, I presented, that patient came with the vertical stigmas, altered mental status, that means drowsiness. The cause is most likely the small vessels disease, or it can be embolism, cardiac or artery to artery. The prognosis is differ from one patient to another patient, or the underlying medical condition. Usually, the statistics says the thalamic infarction is good prognosis is compared to the cortical or subcortical infarction. That is kind of unusual presentation. That's why I presented this one. Any questions?
How did the patient do?
Patient, like next day, patient was better, more weight. So that's usually takes time to recover, but usually it's a good prognosis.
I find it fascinating that a patient came in with drowsiness,
Right.
and it led to the CT scan, which didn't show anything. That was just the thought process of taking it to the next step of an MRI is, you know.
Because it's involved the part of the thalamus that control our wake and sleep pattern. Patient was sleeping a lot. That was the daughter's concern. And initially, actually, patient was sent home from here, and the next day she came back again. It's really unusual presentation, and it's rare also because that's the variant of the artery that involves bilateral thalamus. If it's involved the one thalamus, probably patient will not have that kind of symptom. Because it's involved the bilateral, the sleep-wake cycle or consciousness of state.
So what would the treatment be? Just watch?
So treatment would be the same, like the usual acute ischemic stroke. This patient came with the outer TPA window, so we didn't give the TPA. But the aspirin, antiplatelet, statin, or the other risk factor management, like the diabetes, hypertension. It could be from the small vessels disease. We did not find any source of source like the echo was normal. Telemetry 2 was done. We did not find any evidence of active fibrillation. So that's the aspirin and statin. The aspirin and statin is sent home.
Everyone, I'm Sarah Hancock. I'm one of the PGY2 resident urology. Today, my topic is a little bit outside of the stroke. We saw a lot of stroke and we talk about the stroke. Every conference. Right now, I will talk about a little bit outside the topic, but it can present as a stroke symptoms as well sometimes. I have a patient. It's about 50 years old male, African American. This has been acute onset of left leg twitching for 5 minutes. And actually, the episode just starts from left leg twitching, and it lasts about a few minutes, and then it spread to his left arm and extend like this, and it stay there for 5 minutes again. And between the episode, the patient also noticed some speech difficulty, and also but the patient doesn't have any comprehensive problem in understanding. He's still able to talk to his wife. He denied any confusion and the loss of the consciousness during the episode. And the episode lasts about 45 minutes and then he completely back to normal. He denied any incontinence or tongue biting. And he also had this same thing before, in August the 1st in last year. Review of the system, he denied anything. He doesn't have any headache, he doesn't have any weakness during the episode or before or after the episode. Past history, he had diabetes, high blood pressure. He also had a whole stroke that happened in the right anterior circulation, anterior cerebral artery. This happened about a year ago. And he denied smoking, denied drinking, and no family history of the stroke or seizure. Physical exam, palpation is normal, outside of the neck exam is normal, heart is normal. Neurological exam, everything is normal except he has a wrist defect on the left quadrant, and the defect is a little bit. Otherwise, no weakness. A little bit spasticity on the left side that happened before or after the stroke. Outside of the blood work is normal, and sodium is normal, iodine is normal, pellet is normal. So next step, we did the CAT scan. The CAT scan just showed the old stroke that he already had before last year. It happened on the right atrial function. So summarization on this case, the patient presented with about like a left leg twitching and stiffening and swelling to the left arm is about 5 minutes, and then the patient returned back to normal. It's gonna be like a simple partial seizure in terms of the terminology, and we repeat the MRI on this case, and the patient doesn't have any stroke. So the seizure that happened is come from the stroke that he already had before, and is corresponding to the anatomical localization in terms of the right ACA gonna supply the left leg, and the stroke that happened, and the seizure that happened from the last stroke that the patient already had. So clinical presentation and our impression right now is about the post-stroke seizure and form that look like a symptomatic seizure or symptomatic epilepsy because the patient had at least 2 episodes. First one happened last year and this time with this condition. So today we're going to talk a little bit about the post-stroke seizure because this one sometimes that it can be seen as a new stroke and seizure at the presentation as a new stroke. This can be said especially about some kind of a cardiovascular stroke. Sometimes it presents the seizure without anything. Actually, the incident rate of the post-stroke seizure can be divided into first thing that we call the early seizure after the stroke is happened in 7 days after the onset of the stroke. We have a lot of literature that try to publication about the incident of the post-stroke. At least 5 or 6 publications, but the incident rate of each publication is very low. The incident rate for the early seizure is about maybe something between 3.2% to 17.9%. But the problem is some literature, including intracerebral hemorrhage and ischemic stroke, at the same in one literature, and some of the literature separate between ischemic stroke and intracerebral hemorrhage. That's why the incident rate is varied. And the other incident rate is about the late seizure. This the seizure that happened after 7 days after the stroke. So the incident rate of this thing is varied between 1.3% and 14.1%. Why is this important? Actually, we have a publication from the American Stroke Association in 2004 they try to summarize the impact of the seizure after stroke. Actually, the impact of the early and late post-ischemic stroke seizure, the outcome is still unclear, but I mean, at least if you look at in one literature, I think it's about here, I mean, they show that probably early seizure can increase the mortality rate. But anyway, this publication is happening in 2004, and last year they also do some kind of the, large multi-center study. They try to, this one is a candidate study. They try to think about, summarize the impact of the seizure. They divide a patient like with a stroke into groups, the seizure at the presentation of the stroke and the seizure during the hospitalization. They found that if the patient had a seizure during the hospitalization from the stroke, they increase the incidence of the pneumonia, and the patient need to stay longer in the hospital, and they also increase the mortality and morbidity. But if happened in the less severe stroke, it's not. For the severe stroke, the mortality rate and morbidity is still the same, whatever seizure happened or not. But in the less severe stroke, seizure can increase the mortality rate and morbidity. This is why the seizure after stroke is important. So, who has the risk to develop a seizure after the stroke? Actually, we already know that intracerebral hemorrhage, that this one is potential very high risk to develop a seizure after the bleeding. But the other thing that when you have a ischemic stroke with the hemorrhagic transformation, this one also increases the risk of the seizure as well. The seizure is most likely to happen within a week, after the onset of the stroke. And the other thing that alcoholic consumption also increases the risk of the seizure after the stroke. But for the late stroke, that means the seizure happened more than a week after the onset of the stroke. There is no significant difference between intracerebral hemorrhage or ischemic stroke. So, when we saw the patient with the hemorrhagic transformation from the ischemic stroke and the intracerebral hemorrhage, they increased the risk of the seizure for the first 7 days of the stroke, but they did not increase the seizure after 7 days. But when you think about the stroke that sometimes that happen like this, in this case, that means that it happened in the area that close to the cortex. It can predict the patient may develop the seizure after 7 days of the stroke. It's increased the risk. But this one, they recommend that need more study to have proof that because of there is one positive study and there is one negative study. So they conclude that this one may predict the late onset of the stroke. About the management, actually we have the cocktail review last year about how to manage the seizure after the stroke. Actually, right now so far, there is still no consensus what is the standard guideline for treatment of the seizure after the stroke. On the European guideline, they recommend that if the patient had a stroke and already had a seizure one time, the patient needs to be prophylactic for the seizure with the seizure medication. But they don't recommend to give the seizure medication if the patient just had a stroke and never had a seizure. So no prophylactic for the seizure after the stroke. And for the American Stroke Association, it's still not very up to date. It's still from 2003. This is the recent, the latest guideline that they launched. They still don't have the clear guideline that when to start the seizure medication or what kind of the seizure medication that they would like to start. Actually, we have the study from the UK United Kingdom. They show some of the seizure medication that can give some kind of neuroprotective. It's like a sodium valproate, but that study is not very strong. in a strong study. So this is all of the features that related to the stroke. I mean, right now we don't have enough study to go ahead and kind of making some kind of guideline that to be standardized. And so this one topic, I mean, needs further study. Any question?
I keep thinking AED is defibrillator.
Oh, sorry. Anti-epileptic drugs.
Okay.
Sorry.
So my question is, just so I understand, if there is a stroke, then a seizure occurs, there is no definitive treatment as to you should start them on an epileptic drug or not start them on
Actually, one of the, guidelines from the ILAE, the International League Against Epilepsy, they say that it depends on the location of the stroke. And like if you have a lacuna infarction, the small one in the middle of the brain, and sometimes even between one onset of the seizure, sometimes we don't treat it because we thought that the stroke location may be not related to the seizure. But if one that may present with the MCA with big stroke that related to the cortex and the presentation is corresponding to the stroke location, that's kind of we can treat that. I mean, this case present with the left leg reaching that correlate with the whole stroke that the patient has. That's why we started treatment with the patient.
So does a partial seizure count as a seizure?
What?
A partial seizure, if you say
Yes, that
there's
is
degrees on there's a,
like the absence, like what we partly call an absent seizure.
Oh no, partial seizure is when you have the seizure, but it's just a focal area of the body that's twitching. This one that we call that one. We call when an absent seizure that's in the patient is loss of the consciousness. We call that one of the generalized seizure. When you have a seizure with loss of the consciousness, we call it generalized or complex. We call complex. But when you have the whole body twitching, we call it generalized.
so either one of those would be included in the
Yes.
Okay.
Yes.
So just a practical question, was this patient able to drive prior to this?
Actually not.
No, okay.
For 6 months.
Just to clarify, 3 types of seizures. One is simple partial, complex partial, and generalized seizures. Simple partial seizures, consciousness or awareness will not be affected. So it will be preserved. It will have a focal movement that's somewhat erratic. With complex partial seizures, the awareness can be altered a little, but they will not completely lose it. With generalized seizures, it will be gone. So they will be on the growth. Thank you.
I think today we only
So